So I'm Addie Patterson. I'm one of the physicians at the Movement Disorders Center. I'm finishing my fellowship. I have 2 months left to go in my training. And what I want to talk to you guys about today is medications that are used for Parkinson's disease, general information about what medications are available, and in general, how these medications can affect your lifestyle, and is there any importance to timing of medications related to your food, to protein intake, what is fact and what is myth, that kind of stuff. So we'll get to that at the end. And then we'll kind of also walk through some example cases of how is your doctor thinking about how to change your medications as your Parkinson's progresses with time. Because I imagine a lot of you guys in the audience probably know quite a bit about medications, at least the regimen that you're on, but you may not be thinking about the flip side of it, which is how does my doctor decide what changes should be made based on what I tell them, or what could I be keeping track of better at home so that I can make sure that I utilize my time at the doctor visit to get the appropriate changes made that way. So there are several different types of medications in Parkinson's. The dopamine replacement therapy, there are several different types. One you probably all are familiar with, which is called levodopa carbidopa, or the brand name of this is called Sinemet. But there are also some other formulations of it. So there's a controlled release levodopa carbidopa. That one is a little bit longer acting. So it's more slowly absorbed into your bloodstream, and it wears out of your bloodstream more slowly, but it's also a little bit less potent. So any pill that you take of the controlled release levodopa carbidopa, you only actually absorb about 75% of what it says in terms of the milligrams relative to the immediate release or the regular levodopa carbidopa. So those are the two kind of types of pill bottles that will say levodopa on the bottle. But there are some other medications that are actually also levodopa, just called something else. So there's a newer one called Rytary, which is a capsule that has little beads inside of it that are a combination of short and long-acting levodopa in one. So that's a newer medication option that you guys might not have heard about. It comes, we're still learning how to use it. So the drug company designed it to be a monotherapy or a replacement for regular Sinemet. We're still kind of sorting out whether or not it will truly be as good of a medication as regular Sinemet. You tend to have to take more pills in one day if you're using that Rytary medication, and it's not a direct conversion for your doctor to make, so it's oftentimes a little bit of experimentation in terms of what dose you need. But it's very similar. All of these medications are very similar in terms of what are the benefits and what are the potential side effects. The next medication that works as a levodopa compound is called Parcopa. And most of you probably have not interacted with this medication at all, because what it is, it's just like Sinemet, but it's an orally dissolvable tablet. But it doesn't actually get absorbed through your mucous membrane directly into your blood. It still goes down into your stomach, gets absorbed through your GI tract, so it's really not all that helpful unless you have a problem swallowing. So those are the select patients who, if someone, for example, if you're very stiff and off in the morning, so much to the point that you can't swallow your pill with water, you need something that's going to work without you having to swallow, then you can take that orally dissolvable tablet. But it doesn't necessarily work immediately like something that gets directly absorbed through your mucous membranes. The last one that works by this same mechanism, by replacing levodopa directly, is also a little bit new. It's a surgical therapy called Duopa. And so it's actually a little tube that goes into your stomach or just past your stomach, and you wear a little, basically, like a little pouch that contains the medication, and it infuses it all day during the day. So you're on a prescribed rate as determined by your doctor how much you need, and then you're getting kind of a smooth, steady state throughout the day. But these are all directly replacing levodopa. So now we're going to move on to the next category of medications, which is something called COMT inhibitors. So probably a lot of you are not on these medications, but the goal for these medications is once you get the levodopa broken down, so you get it up into your brain, it gets turned into dopamine, and that's what you need. These COMT inhibitors try and prevent it breaking down in your bloodstream before it gets up to your brain. So it keeps more levodopa lingering around in your bloodstream so that it can get slowly absorbed into your brain, because your body's always trying to break down that levodopa. So these can extend the life of Sinemet. They don't do anything if you take them by themselves, because the only thing they do is prevent the breakdown of the artificial dopamine. So they help to extend the life of the medication, and they can be pretty helpful, early on in the course of Parkinson's. The risk with these medications is that sometimes they can also increase the side effects. So you have more lingering around for longer, and that can increase dyskinesias, or the extra wiggly movements you can get as a side effect of the dopamine. And it can sometimes increase things like nausea or hallucinations if you're experiencing those already. So those medications can be helpful to extend the life in certain patients, but they can cause side effects in certain patients too. So that medication is called entacapone. That's the compound that extends the life of the levodopa, and then there's a combination pill that's called Stalevo that you guys may have heard of. So the next category that we'll talk about is the dopamine agonists. So instead of being a direct precursor to dopamine, which is the levodopa or Sinemet compound we talked about, these are actually a synthetic dopamine that goes directly to the brain and binds to those dopamine receptor sites that are lacking dopamine. So they're theoretically really similar to levodopa, but in reality they're a lot different in terms of the side effect profile and who they're good for and who they're not so great for. So these medications, examples are Mirapex or Pramipexole, Requip or Ropinirole, and Nupro or Rotigotine, that's the patch form. And then there's also an injectable form, which we use sometimes as a rescue therapy that works by the same mechanism called Apokin. So these medications a lot of times will be used earlier in the course of Parkinson's, or in patients who are younger, who don't have a lot of non-motor symptoms. So people who don't have a lot of hallucinations or memory trouble or mood trouble. They can also be used as an add-on to Sinemet. Sometimes the thinking is that, well, if we give you two medications, one from one class, one from another class, then the additive effect will be greater than being on a higher dose of one or the other. So we use them sometimes in combination early on in the course of Parkinson's. And then as time goes on, if you develop hallucinations or cognitive troubles, then we usually start to peel back on that dopamine agonist medicine first. It's not good for anyone who has ever experienced something we call impulse control disorder, or a problem where you feel really driven to do something that you shouldn't do, like gambling, hypersexuality, compulsive shopping, overeating, things like that. If you're driven to do something that you shouldn't do, and you never did that before, and then you started this medication, and it drives you to do that, then that's something you have to tell your doctor, and we peel you off of it. The problem is sometimes even doctors, it's our fault, we don't tell you this, and you think it's a personality problem or something, intrinsic to yourself that you've done. And so a lot of times we don't hear about these things until we specifically ask. So that's important for everyone to know. If that happens to you, really on any medication, if you suspect that it's triggered by a medication, tell your doctor and they might want to make a switch. So one of the medications I just want to hit on that I mentioned called Apokin. So that's a true rescue medication. So unlike the oral dissolvable one, the Apokin is actually a subcutaneous injection. It's only used for very select cases where you need a rescue therapy that's going to act right now. Like if you have sudden wearing off of your medication and you can't move, you can't do anything. So that's who the Apokin is designed for. You would administer this injection and it is absorbed directly and it enables you to get moving quickly. So that's really the only true rescue medicine we have. But it's a more high-risk medication, and so you actually have to be monitored in the clinic the first time you receive a dose. Part of it is for cardiac monitoring to make sure it doesn't drop your blood pressure too much, and then also to see what dose you need when you go home. And it's extremely expensive. Anyone who's ever had any experience with it probably knows it's, I think, thousands of dollars a month. But it's available, and for the right patient, we do use it sometimes. So those are the dopamine agonists. The other thing I'll mention about those is that sometimes they can be quite helpful for restless legs. We use them in people without Parkinson's who have restless legs. And if you have a lot of restless legs as part of your Parkinson's symptoms, then sometimes these medications can be really helpful. So the next class we'll talk about is called the MAO inhibitors. And so these are medicines like Azilect or Rasagiline or Eldepril or Selegiline. So there's only 2 right now. I believe the FDA just approved a 3rd medication from this class just a couple of days ago, but it's not commercially available yet as far as I know. But these medications, what they do is so all of the dopamine that you do have floating around in your brain, even though it's not the normal amount that you used to have, whatever dopamine is there gets broken down over time. And so this medication prevents it getting broken down within your brain. So unlike the COMT inhibitors like the entacapone, which don't work unless you're taking a dopamine synthetic compound, this can work even on your own natural dopamine to prevent it from getting broken down. So it can be used alone or it can be used in combination with other medicines. So these are usually really mild in terms of providing benefit, and they're really mild in terms of causing any side effects. So most people tolerate them pretty well, but if you really need a big bang for your buck, these aren't the strongest medicines. You guys may have heard some questions in your reading about, is Azilect something that's going to delay the progression of my Parkinson's disease? So that's something it's still a little controversial. There have been 2 studies about it. One said it didn't show any benefit, and one said maybe it showed benefit, but they tested it at 2 doses and it only showed benefit at the lower dose, which doesn't really make a whole lot of sense. So no one knows whether we necessarily want to believe that or not. But right now here we have some researchers who are doing a study about Azilect, actually looking at the part of the brain affected in Parkinson's called the substantia nigra, and taking a measurement of how big that area is, or what does it look like, how healthy is it, and then does it stay healthier for longer if you're on Azilect for 1 year's time. So it's still kind of an ongoing question that's not fully answered. What we usually say is, if you're a good candidate for it anyway and you need something for small symptomatic benefit, we can use it, but if not, then we don't necessarily know if it's truly delaying the disease progression. So the next thing is, there are 2 medications that don't really fit nicely into any of these medication classes. One is called amantadine. It's a medication best used for patients who are in mid stages of their disease that are starting to have a lot of dyskinesias from their levodopa. And so what it can do is calm down the dyskinesia a little bit in some patients. So usually if you're on Sinemet and you're noticing emergence of some dyskinesias and they're starting to bother you, your doctor might put you on amantadine to see if it can calm down your dyskinesias. And even by itself, in very early Parkinson's disease, we can give it, and it does help with some of the Parkinson's motor symptoms. The last one that I'll mention, which maybe 1 or 2 people in this room could be on, but I doubt many, is called Artane or trihexyphenidyl. This is a medication so all the other medications we talked about globally help with most Parkinson's motor symptoms. The Artane only helps with tremor and dystonia. So it doesn't help with all of the other symptoms, and it can cause a lot of cognitive troubles and hallucinations. It's from a class of medications that we call anticholinergics, which is the same class of medications for things like Benadryl. Any of you guys who were listening to the talk in the other room before this one, they mentioned, these medications can trigger hallucinations, they can trigger a lot of things we don't want. So we really reserve the Artane or trihexyphenidyl for young people who have a very bad tremor, who we don't think are going to develop any memory trouble or hallucinations. So it's very select patients who could have that one. So let's see what else. So let me walk you through some sample patients and kind of help you start thinking the way your doctor's thinking about your medicines and what they decide to do for you. So we choose a unique regimen for each unique patient, but let's give an example case. So this case, we'll say it's a 45-year-old woman who has had a right hand tremor for 1 year. She's diagnosed with Parkinson's. she has all of the motor symptoms of Parkinson's, but none of the non-motor symptoms. So she's not having depression or memory trouble or hallucinations or anything like that, and she's not on any medication right now. So this patient would be a candidate for almost anything. So we, of course, wouldn't need to do something like the injections or an infusion pump in her stomach, but we could give her Sinemet. We could give her a dopamine agonist like ropinirole or Mirapex. We could give her something mild like Azilect or Selegiline. Or we could even give her amantadine because that can be used sometimes early in the course of Parkinson's without too much trouble. So the sky's kind of the limit in a young person without any non-motor symptoms. What we typically do is something like Azilect or a dopamine agonist in a young person early on. But really, there's no wrong answer for that patient. Then moving on to someone kind of in the mid stages of disease. So now this is a 60-year-old man, and he is starting to have motor fluctuations. And what that means is he takes his medication, it kicks in, maybe once it's at the peak, he's having some dyskinesia movements, and then when it wears off before the next dose is due, and then he's miserable for 15 or 20 minutes till that next one kicks in. So that's what we mean by motor fluctuations. Sometimes he's having too much movement, sometimes he's stiff and frozen. So what could we do? He's already taking carbidopa, levodopa, or already taking Sinemet. So what your doctor would do if this were you, we would say, okay, tell me exactly what time are you taking your medications, and if you feel it kicking in, how long does it take before it kicks in? And when it's at its peak dose in your body, are you having any side effects? So are you having any dyskinesia, wiggly movements? Are you feeling lightheaded? Are you having nausea? Are you ever getting any hallucinations? And then how long before it wears off? So not everyone feels this kicking in and wearing off, but we're saying this is a patient who's had Parkinson's long enough and he does feel that. So if he told us, well, it kicks in after 30 minutes and it wears off after 2 hours, but I take it every 3 hours, then we could shorten the dosing interval. And that would be a reasonable thing to do. Another reasonable thing to do would be to add a medication to extend the life. So we talked about that there are 2 medications that do that. One is the entacapone, which can extend the life by preventing breakdown in the bloodstream. And the other is Rasagiline or Azilect or Selegiline, which can extend the life by preventing breakdown in the brain. So we could do either of those things. Or another option would be we could add something else, like we could add a dopamine agonist like Requip or Mirapex, because we said he's a pretty healthy guy, he's not hallucinating, he doesn't have any memory trouble, we could add a second medication. So those things, your doctor would give you options and say, okay, here are the 2 things I think would be reasonable for you. What should we do? What would you like to do? Then our third case will say, now this is someone with more advanced Parkinson's. So this man is 85. He's had symptoms of Parkinson's for 10 years. He has severe stiffness, he has slowness, he has balance troubles, and he now, unlike the other 2, has memory troubles and hallucinations. And we'll say he's already taking Sinemet too. So what can we do? So unlike the first lady, who was young, healthy, no memory trouble, no hallucinations, the sky was the limit for her. For this patient, we want to be really careful because almost all of the medications can cause side effects and make those symptoms worse, the memory trouble, the hallucinations, and the dyskinesias. So we have to be careful. And for patients who are in the scenario like this gentleman, we usually stick with the levodopa, carbidopa, or the Sinemet. It's tried and true. It has the least amount of side effects that are going to negatively impact those areas of functioning. So if he got to this point and he was already on many medications, what we would actually do is instead of increasing something, we would probably start to simplify. So we would start to peel back medications that we know can cause side effects, try to simplify the regimen to just Sinemet, and see what we're left with. So sometimes at this point we need to start, if we can't get rid of the hallucinations and they're troublesome, we need to start adding medications from a totally different class to try and block the hallucinations. Okay. So let's talk about lifestyle considerations. So I talked about lots of different medications in terms of their name and how they work, but what are the practical aspects of these medications? Is there anything, everyone wants the golden ticket. I want to take my Parkinson's medication 1 time per day. I want it to be long acting. I want it to be smooth and perfect and ideal. So that doesn't exist yet. I hate to break it to you, but there are some medications that require less frequent dosing. So for example, the Nupro patch is from the class of dopamine agonists or synthetic dopamine replacement. It's a once-a-day patch. It's fairly convenient. Again, not everyone's a good candidate for it, but you just stick it on your skin, hold it, activate the glue, and leave it on and forget it. It's usually not strong enough to be used alone, but it can be a convenient medication for people who are really concerned about either taking pills or frequently dosing their medications. Other medications that require less frequent dosing are Sinemet controlled release. It's controlled release, but it's not once a day. It still ends up being several times a day, but it can extend the life a little bit. And then the Stalevo medication we talked about, which is Sinemet plus the extender medication, can sometimes allow you to space out the dosing throughout the day. So if you were, say you were going to take your have to take it every 3 hours, maybe now you can take it every 4 hours. So it's not a dramatic extension, but sometimes it can extend how often you need to take your medications. Let's see. The other things to think about are, there are things that can be very convenient for some people and an inconvenience for other people. So we talked about the Duopa gel. So it's like the Sinemet, but it's an intestinal gel. So some people say, well, that sounds great to me. If you just put that pump on me, let it run, I don't have to take any pills, except for at nighttime, that sounds great. And then some people say, oh my goodness, a tube in my stomach, that could get infected. I don't want to wear a pouch around. That's a very patient-dependent thing. But for some patients, that's a good option when they're dosing their medication every 2 hours and bouncing up and down between, side effects and a frozen off state. It can be a good option. The other things we talked about, the dissolvable pill, which, like I said, isn't an instantaneous relief. And then we talked about the Apokin injection, which we talked about can be more instantaneous relief, but it comes with a lot of side effects and it's really not for everyone. Then, outside of medications, there are surgical options, which they're talking about in the other room, and you guys can watch the recorded presentation on that online after today. So there are surgical options for certain patients at certain stages of the disease that can be helpful too. So what about how does my food intake interfere with my medication? So if a lot of you guys have probably heard, don't take your Sinemet with food. So why do we say that? So there's a theoretical risk that protein can interfere with how well you absorb your Sinemet medication. So we think it's an effect that's mainly limited to Sinemet and not the other Parkinson's medications. But in reality, they took a look at this. There was a study at Columbia of about 1,000 plus patients, and none of the patients who had been on Sinemet for less than 3 years had any interference of protein with how well their medication worked. The patients who were already having motor fluctuations, meaning they could feel it kicking in and wearing off, and they were having some times of the day where their symptoms weren't controlled, those patients were more likely to notice interference of protein with how well their medication worked. But even of those patients, only 12% said that they had that problem. So what do we learn from that? Well, to me it says, if you notice a difference, then separate it from your protein meals. If you don't notice a difference and you're not a motor fluctuator, your medicine works well, then you can take it with food. It's a person-to-person dependent thing. Some people say, well, if I'm ever going to have to separate it from food, then I'd rather just get in a routine now. And that's a good way to approach it too for a lot of people. The other thing people ask us about is how strict of a schedule do I really have to follow with these medications? You tell me take it when I wake up and then take it every 3 hours. What if some days I wake up at 8, some days I wake up at 10? Do I set an alarm and wake it up so I can take it in the middle of the night while I'm sleeping? What do I do? So that's kind of the same thing. We like our patients to be on a strict schedule. Part of it is, we're all kind of OCD as doctors. We want you to be able to say, I take it at this time, this time, this time. This is exactly when it kicks in. This is exactly when it wears off. It's easy for us to adjust your medications if you take it at exactly the same time. And the truth is, early on in the course of your Parkinson's, you probably won't notice too much of a difference if you're 30 minutes late. But as the disease progresses, that strict schedule becomes critical. And the reason for that is that early in your Parkinson's, you're still making a lot of your own dopamine. So you have a background floating around of dopamine in your brain that's doing some work for you. So you only need medication to make up, say, this much of a gap. So anyway, early on in the course of Parkinson's, you have a lot of your own dopamine, not a lot, but you have a good amount of your own dopamine floating around, helping you with those motor symptoms. You only need medication to make up this certain amount. And so we say in that kind of scenario, the therapeutic window is large because we can give you your medication. You're not going to dip down so low because you're protected by having some of your own dopamine, and you're not at as high of a risk for going into a peak because you're taking less medication because you don't need as much. Then as time goes on, your natural dopamine starts dwindling down. And so now you need to fill a bigger gap, so you need to take a higher dose, and you have less of your own when the artificial medication has worn down. So now the therapeutic window for where you're feeling good is smaller, and you're kind of ping-ponging between not enough and too much, and it's almost unavoidable. So that's why it becomes very important as Parkinson's progresses and you start feeling those peaks and valleys that you're on a strict schedule so that we can keep your symptoms controlled, if that makes sense. So early on, you probably won't feel a difference. We like you to be on a schedule, but it's probably not 100% critical. And then as time progresses, it's really important and you're going to start to feel it. So it's better to get in a routine. And then the question of, do I need to set an alarm in the middle of the night? So most people don't, but if you're somebody who gets, you wake up in the middle of the night, you don't know why, you think it's because you had to go to the bathroom, but you're feeling really stiff and slow, and the first thing in the morning is your absolute worst time of day, then your doctor may put you on a dose that you would take in the middle of the night when you wake up at that time. Most patients don't need to set an alarm to take a medication in the middle of the night. There are always exceptions, but that's in general. Okay. All right, I think I'll go ahead and stop here and give you guys a chance to ask questions. I apologize that the connection wasn't working for the PowerPoint, but hopefully it went okay and we didn't have to stop so many times. Go ahead.
What is the maximum dosage of Cinnamon? I mean, what's to the point where you can't take any more?
So the maximum dose is really dependent on side effects. So for some people, they'll hit side effects at a relatively low dose. And for some people, they're on oodles of Cinemet and they don't get side effects. And so we're able to increase it. There's no true maximum.
Can you give me
So
a number?
an example, some of our patients would take 2 pills every 2 hours around the clock.
The 25, 100?
Mm-hmm. Something like that. So they would be getting, over 2 grams of levodopa in a day. But it's really just, it depends on you, what side effects you're having. The pharmacy will have a different opinion on what's the maximum dose, and sometimes we do get called saying, are you aware that this is a very high dose of Cinemat or levodopa? And then we just have to say, yes, we're aware, we're monitoring, we're seeing you every 3 months, we know you're tolerating it, we're monitoring for side effects, and that's that. Go ahead.
The concern about the protein, does it matter if you take your pills in a certain amount of time after you've eaten something, as well as, do you eat something first, then you take the pill, then you take a time out?
So if you feel like you do have a protein interference with your medication, then the way we normally tell people to do it is give some time before and after. So you would want to, if you're going to eat after your pill, then you'd want to give your pill 30 minutes of a head start to get working until you eat. And then if you're going to take your pill and then eat, then you want to give it a little longer, maybe 45 minutes or even an hour after you take that pill before you
How
eat.
do you determine that you've had the protein interference or whatever you're calling it?
Well, it's basically trial and error. So if you feel like it works really great if I take it on an empty stomach, and then if I take it with food, ooh, that didn't work as well, then you tell us that feedback, and then we suspect that the culprit could be protein interference. The best way to do it is just, if you're wondering, just stay on a strict schedule of, half an hour before, an hour after, and if you feel better doing it that way, then do it that way, and if you don't notice a difference, then you can, stay on a timing-based schedule, but not necessarily work your meals around it.
Half an hour before, not an hour before, but a half an hour before.
Well, different people will tell you different things, but usually patients tell us that a half an hour of a head start is adequate. Any other questions that you guys have? You have one?
Yeah,
Go ahead.
is there anything coming out in the future that's going to help us out at the progression of these diseases?
So there are some interesting trials coming. Well, in terms of medications, I mentioned that there's a new MAO inhibitor that's recently FDA approved. I imagine it'll probably be kind of a mild medication like the other MAO inhibitors, like the Azilect and Selegiline. There is also an inhaler form of the levodopa that's gone through clinical trials and I believe should be coming out. I don't know when. And then in terms of other things that are working by totally different ways, there's a lot of research going on in terms of infusions and things of that nature that could possibly be helpful for patients who are living with Parkinson's right now. But I can't tell you, if that'll come to fruition or not, but that's something that's being studied now.